Before you touch a drill, check the D. Across thousands of implant cases, the same quiet pattern keeps appearing. Early failures, delayed osseointegration, unpredictable graft healing, and again, one blood marker sits in the background: serum 25-hydroxy vitamin D. Patients don't feel it, surgeons don't see it, but biology reacts to it every single time. Some call this internet hype, others call it pseudoscience. But the data keep pointing in one direction, and the consequences are too costly to ignore. Today, we strip away the noise and ask one question that actually matters. Is low vitamin D quietly sabotaging your implant outcomes? After 30 years in surgery, I've learned one brutal truth: biology always wins. On this channel, we go beneath the surface, how the body responds, how it resists, how we work with it instead of against it, and how disciplined surgical systems turn chaos into predictable outcomes. Welcome back. Today, we're diving into vitamin D and early implant failure. Human data are not perfect. Most studies are retrospective, but the pattern is stubborn. When serum 25-hydroxy vitamin D is low, early implant failure goes up. In large retrospective cohorts, failure clusters in patients with deficient vitamin D. Case reports show implants failing to integrate in severely deficient patients, then succeeding once vitamin D is corrected and the site is retreated. Systematic reviews keep using the same language: suggestive, limited, more studies needed. But here's the point: different centers, different study designs, similar direction of effect. Every time we measure vitamin D properly, deficiency is never neutral. It's never a harmless background detail. It's a systemic risk factor sitting underneath your mystery failures. Vitamin D is not just the bone vitamin, it's an immune conductor. Its active form, calcitriol, binds nuclear receptors on macrophages, osteoblasts and osteoclasts, and rewrites their behavior. It pushes macrophages away from M1 pro-inflammatory phenotype towards the M2 pro-healing phenotype. That early macrophage switch is not a detail. It decides whether your surgical wound stays inflamed or transitions into regeneration. Vitamin D also induces LL37, a natural antimicrobial peptide lowering infection risk in early wound healing. It regulates osteoclast-osteoblast crosstalk, guiding a controlled remodeling response instead of chaotic resorption. In animal models, when vitamin D is low, bone-to-implant contact drops, new bone formation slows, osseointegration becomes fragile. Correct the deficiency and the bone contact and stability return, even in diabetes, osteoporosis, and other compromised states. This is not a wellness biology, this is hard skeletal immunology sitting at the base of your fixtures. Human studies are inconsistent, but the signal is there. Animal and cellular data is clear, mechanistic, and strong. The mechanism: vitamin D shifts immunity, angiogenesis, and remodeling in the exact time window that implants live or die. Next, we bring this down to what you actually see: graft behavior, thresholds, and chairside workflow. Bone grafts don't heal just because we fill the space. They need angiogenesis, immune resolution, coordinated remodeling inside and around the scaffold. Vitamin D is woven into all three. When systemic vitamin D is low, preclinical studies consistently show weaker vascularization invasion into grafts, more persistent inflammation, less organized new bone inside the defect. And this holds across graft types: autogenous, allograft, xenograft, synthetics. When vitamin D is sufficient, bone volume fraction rises, vascular density improves, and the interface between graft and host looks like regeneration, not chronic irritation. Clinically, you've already seen the phenotype: the slow healer, the marginal graft that never quite matures, the sinus that looks hazy for months. Many of these patients live at the bottom end of the vitamin D curve. Here's where it gets confusing. Public health guidance in the UK aims to prevent rickets and osteomalacia, not optimize surgical healing. Most guidelines recommend about 400 international units per day for general adults. That's fine for population level bone health, but around implants and grafts, many clinicians work with different cut points. Deficiency when there is 20 nanograms per milliliter. Insufficiency when there's between 20 to 30 nanograms per milliliter. Sufficiency when there's 30 nanograms per milliliter and above. In real implant practice, a common pragmatic target is to get the patients to at least 30 nanograms per milliliter before elective implant placement or major grafting. Some surgeons push even further for extensive sinus and stage reconstruction work. Above 50 nanograms per milliliter, you don't gain more healing, you just start flirting with hypercalcemia and abnormal bone turnover. So the goal is simple: not as high as possible, but into a physiological zone where the biology can do its job. This is how you turn theory into a repeatable protocol. Step 1. Screen the right patients 6-8 weeks prior to surgery and identify high-risk groups: minimal sun exposure, darker skin tones, obesity, malabsorption or bariatric surgery, older age, diabetes, chronic kidney disease, history of early implant failures, mystery slow healers in your own practice. Step 2. Test serum 25 hydro vitamin D. Order a simple blood test because you want to know the number before you load the case with risk. Step 3. Correct any deficiency. If levels are below 13 nanograms per milliliter, coordinate with the patient's GP or physician. Short-term higher dose correction and then maintenance in the range that the local medical guidance specifies. Step 4. Time your surgery. For large grafts, sinus work, or multi-implant cases, schedule surgery when their levels are documented as corrected. Step 5. Maintain through integration. Keep supplementation going through the integration period. Reinforce adherence at suture removal and again at uncovering or prosthetic connection. And step 6. Avoid mega doses. More is not more. You want physiology, not pharmacology. What about just get more sun? Human skin has a built-in cap. Under strong UVB, full body exposure can produce about 10,000 to 20,000 international units of vitamin D3 in a day. After roughly 15 to 60 minutes, production saturates. Surplus UV light simply converts precursors into inactive photoproducts. Light skin reaches that ceiling quickly. Darker skin may need 3 to 10 times longer for the same synthesis. Art real life, UK latitude, winter, clothing, indoor work, sunscreen. And you quickly realize you cannot rely on sunlight alone to keep high-risk implant patients out of deficiency. Sunlight is a bonus, it's not a protocol. Hype versus reality. Let's strip this down. Hype. Vitamin D prevents peri-implantitis. We have no high-level evidence for disease prevention. The reality? Vitamin D deficiency is a modifiable systemic risk that influences early bone healing, inflammation resolution, and osseointegration probability. Correcting deficiency is cheap, safe, and biologically coherent. It will not rescue post-surgery. It will not compensate for bad prosthetic planning, smoking, uncontrolled diabetic, or chaotic occlusion. But it can shift the curve in your favor on those early, frustrating failures that should have worked. So here is the simplest upgrade you can add to your implant protocol alongside CBCT, medical history, and biomechanical planning. Add one checkbox: vitamin D. Screen, correct, maintain. Stay within safe limits. A small systemic lever with a strong biologic rationale, growing clinical support, and almost zero downside when done properly. Thank you for watching. Please like and subscribe.